Pectus Excavatum, PE, also known as funnel chest or trichter bruise, is by far the most common chest wall deformity, occurring in 1 of every 400 white male births. Pectus Carinatum, PC, the next most common chest wall deformity, is 5 times less common than Pectus Excavatum. For more than half a century, the traditional method of repair for Pectus Excavatum was the modified ravage repair. In 1998, a minimally invasive method of repair, the NUS procedure, was introduced. Several theories explain the cause of Pectus Excavatum, however, the etiology remains obscure. Some other authors believe that Pectus Excavatum may be due to an overgrowth of costal cartilage, which displaces the sternum posterior. Abnormalities of the diaphragm, rickets, or elevated intrauterine pressure are also theorized to cause posterior displacement of the sternum. The coexistence of Pectus Excavatum with other musculoskeletal disorders, such as Marfan syndrome, suggests that an abnormality of connective tissue may be involved. Pectus Excavatum is generally present at birth or arises shortly thereafter. Pectus Excavatum is more common in males than in females, with a male to female ratio of 6/5. Pectus Excavatum generally has no discernible physiological effect on infants or children. Some children have pain in the area of the sternum or costal cartilage, especially after vigorous exercise. Other children have palpitations that might be related to mitral valve prolapse that commonly occurs with Pectus Excavatum. A flow murmur may also be detectable in some patients. This flow murmur is related to the close proximity of the sternum to the pulmonary artery, resulting in transmission of a systolic ejection murmur. Asthma is sometimes noted in children with both Pectus Excavatum and Pectus Carinatum. The sunken appearance of the chest wall has been associated with poor self-image in children, especially as they approach adolescence. The major indication is currently psychosocial. Improvement of the appearance of chest wall after repair improves socialization. In competitive athletes in whom a slight decrease in exercise tolerance may impair their performance, surgeons may also choose to repair the Pectus Excavatum. Other indications include a failed previous repair. Regarding treatment for Pectus deformities, the authors concluded that the modified ravage procedure remains a safe and effective approach to the repair of Pectus deformity in all of its presentations. Because the technique rarely uses a metal strut, a second procedure for strut removal is not necessary. Minimally invasive repair of Pectus Excavatum, the NUS procedure, involves inserting a custom bent curved metal bar underneath the sternum through lateral chest incisions. The bar is then turned, placing the convexity of the upward, correcting the pectus depression. The bar is then secured to the lateral aspects of the chest wall, ribs, or both, and left in place for 2 to 4 years, after which is removed in a second procedure. Regarding Pectus Carinatum, the pigeon chest or Pectus Carinatum is the second most common congenital chest wall deformity. It constitutes approximately 7% of all anterior chest wall deformities. It is more common in boys than girls, ratio 4/1. It is typically apparent at birth and tends to worsen as the child grows. Pectus Carinatum is typically thought of as a protrusion of the chest wall, the opposite of Pectus Excavatum, but actually represents a spectrum of deformities that involve the costochondral cartilage and sternum. Costochondral cartilage involvement may be unilateral or bilateral. In addition, the sternal protrusion may be superior or inferior. The defect may be asymmetrical, causing a rotation of the sternum with depression on one side and protrusion on the other. A genetic predilection may be present because 26% of patients have a family history of chest wall deformity. Furthermore, 15% of patients also have scoliosis, congenital heart defects, Marfan syndrome, or other connective tissue disorders. Regarding treatment, it is generally surgical. Ravage reported the first surgical repair of carinatum defect in 1952. He described a method in which resection of abnormal cartilage was combined with double osteotomy of the sternum to elevate the defect. The modern method of repair is based on the procedure described by Ravage and Voss in 1973. Minimal access techniques as Abramson technique involves inserting a custom bent curved metal bar underneath the sternum through lateral chest incisions have now been applied to Pectus Carinatum.